Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY4 resident in radiation oncology at the University of Pittsburgh, and today we are wrapping up our series on breast cancer with a discussion on radiation regimens that we actually use to treat patients. As with every other talk that we've had for breast cancer, there is just far too much information to be able to possibly cover, so we're not going to hit every single trial that has been done and every single radiation regimen that you could use for breast cancer. But what I will try to do is present some of what I think are the most commonly used regimens for breast cancer, starting with moderately hypofractionated regimens and then going into extremely hypofractionated regimens, as well as partial breast irradiation and re-irradiation. If you've been following along with the breast cancer series so far, you've heard me say several times that in the old days, we used to treat patients with radiation over 5 to 6 weeks, and in the modern era, we're able to get away with 3 to 4 weeks at most. And so in this talk, we're finally going to unpack that and kind of learn these exact regimens and what they are and what the evidence for using them is. So in the old days, we used to utilize conventional fractionation. And when we say conventional fractionation in general, we typically mean 1.8 to 2 gray per fraction. So as I said, in the old days, we were giving 2 gray per fraction for a total of 50 gray. So this was 25 fractions Monday through Friday, and it took 5 weeks to deliver this treatment. And if patients required a boost, it was an additional 10 gray and 5 fractions over an extra week. So that's where we get 5 to 6 weeks from in the conventional fractionation era. Now, why did we even start thinking about moderate hypofractionation? Why did we wonder, can we maybe increase the dose per fraction and then get away with using less fractions? So the rationale for this is actually that breast cancer, similar to prostate cancer, is thought to have a lower alpha-beta ratio. And if you haven't learned yet what alpha-beta ratio is, that's okay. Basically, we give tissues a number usually from 1 to 10, and that describes their alpha-beta ratio. And it's kind of a numerical indicator of how sensitive the cells are to fractionation. So breast cancer and prostate cancer are thought to actually have lower alpha-beta ratios, and all that means is that they are thought to be more similar to late responding tissues in that they are more sensitive to the dose per fraction. And so the thought is that maybe to kind of exploit the therapeutic ratio and make the radiation work a little bit better in these tumors, they may actually benefit from using a slightly higher dose per fraction and then decreasing the number of fractions. That's kind of all that means. So that's where the rationale for treating patients with moderate hypofractionation even came from. And the regimens that were used ranged from 15 to 16 fractions given over 3 weeks. And when we say moderate hypofractionation now, we're giving a slightly higher dose per fraction. So somewhere between 2.5 to 3 gray per fraction when we talk about breast cancer. So the big takeaway is conventional fractionation was 2 gray per fraction. Moderate hypofractionation, we're now giving 2.5 to 3 gray per fraction, and seeing if we can get away with fewer treatments but a higher dose per fraction. So let's take a look at some of these trials. So the first study to actually publish long-term results with moderate hypofractionation came from Canada. And this Canadian regimen, the trial was run by Dr. Whalen and team. That's a name that you'll see often in these breast cancer trials. So in the Canadian trial, they compared the conventional regimen of 50 gray and 25 fractions to 42.56 gray in 16 fractions given over 22 days. So remember, with conventional fractionation, we were giving 2 gray per fraction, and with the moderately hypofractionated regimen of 42.56 gray in 16 fractions, we were giving 2.66 gray per fraction over 22 days. So that means, it was Monday through Friday, 16 fractions Monday through Friday with weekends off. It's important anytime you're looking at a trial to kind of note what the inclusion criteria are for the trial. So in this trial, they excluded patients with positive margins, any patients with positive nodes, tumor greater than 5 centimeters, or breast separation greater than 25 centimeters. I think a picture is worth 1,000 words in this case. So I didn't know for a long time what was meant by breast separation. Breast separation is kind of the distance if you take a look at a patient's CT scan in the axial plane and you measure the distance from the patient's mid-sternal line to sort of the lateral mid-axillary line. That diagonal line that you draw from those 2 points on a CT scan is kind of the breast separation, and it gives you an idea of how voluminous the breast is. And so the idea is that if the breast separation is greater than 25 centimeters, that's a larger breast, and it ends up being a more heterogeneous plan when you plan the radiation. And so that's why they excluded patients with a breast separation of over 25 centimeters. So when they compared these two regimens, the conventional 50 gray and 25 fractions to the moderately hypofractionated 42.56 and 16 fractions, and keep in mind they did not deliver any regional nodal irradiation and they did not allow any delivery of boost. They found that there were no significant differences in local recurrence, survival outcomes, or toxicity. So the 10-year local recurrence was just around 6% in both arms. The 10-year overall survival was around 85% in both arms. And they found no significant difference in terms of toxicity or cosmetic outcomes. And so the 42.56 gray and 16 fractions was deemed non-inferior to 50 gray and 25 fractions for pathologic T1 to T2 N0 tumors with negative margins. Because remember, they did not allow tumors that were 5 centimeters or greater, which would make you T3, and they did not allow any patients with pathologically positive nodes. One thing to note for the Canadian trial, in their initial publication on subgroup analysis, it actually suggested worse local control in high-grade tumors. But this was actually refuted in an updated analysis, which showed no difference in outcome based on the grade. So for a while there, there was some worry that this regimen may not be acceptable in patients with high-grade tumors if they had worse local control outcomes. But the updated analysis actually showed that there was no difference. And so, there's no reason to not utilize this fractionation regimen based on a high-grade tumor. So the takeaway from the Canadian trial, the regimen is 42.56 gray in 16 fractions, and it's non-inferior to 50 gray in terms of outcomes as well as toxicity. At the same time that moderate hypofractionation was being studied in Canada, it was also being studied in the UK through the UK START A and B trials. These trials, however, were a little bit later to publish their 10-year results, just around 3 years after the Canadian trial. So UK START A and B looked at a few different regimens. The START A trial compared conventional 50 gray and 25 fractions to a couple different regimens, 41.6 gray and 39 gray, delivered in 13 fractions over 5 weeks. So you're giving fewer fractions, but you're still taking 5 weeks to deliver all of it. UK START B compared conventional fractionation to 40.05 gray and 15 fractions given over 3 weeks. So every day, Monday through Friday, over 3 weeks. So now we're giving 15 fractions every day, Monday through Friday, and we're only taking 3 weeks total. So UK START B, spoiler alert, is kind of the winner, and 40.05 gray and 15 fractions is sort of the regimen that won from all of this. So we'll sort of focus on that one. This trial also ran in kind of the early 2000s, and they took patients with pathologic T1 to 3A tumors, so a little bit larger now than what the Canadian trial included. They also allowed PN0 to 1 M0 disease, status post either breast conserving surgery or mastectomy. And both groups, they did allow the delivery of a 10 gray boost, and they did also allow regional nodal irradiation. So around 15% of the patients received regional nodal irradiation with this scheme. So just keep in mind that the UK trial allowed slightly more advanced disease compared to the Canadian trial. They also allowed patients with mastectomy, and they allowed regional nodal irradiation. So in terms of the 10-year results, when they looked at 50 gray versus 40 gray and 15 fractions, there was no significant difference in local relapse compared to conventional fractionation, just around 4% in both arms. Importantly, the moderate or marked breast shrinkage, telangiectasia, and breast edema were significantly reduced in the 40 gray and 15 fraction arm. So the late effects were improved with moderate hypofractionation. Additionally, there was no significant difference in lung, heart, arm, or shoulder toxicity. So the takeaway is that 40 gray and 15 fractions is at least as safe and effective as 50 gray and 25 fractions, and it actually causes less harm to the normal tissues, so less of those breast-related late side effects, especially breast shrinkage and telangiectasias. And so the UK had actually already started adopting this regimen, the 40 gray and 15 fractions, based on the 5-year results of UK START A and B. And I think the United States was a little bit later to adapt this. But at this point, pretty much everyone always is using moderate hypofractionation, so 15 to 16 fractions if we're doing whole breast irradiation. And this is true even in patients who are receiving regional nodal irradiation. So if you need a little bit more evidence, the DBCG Hypo trial showed no significant difference in toxicity for 15 fractions for early stage breast cancer or DCIS. So if we're doing whole breast irradiation for DCIS, again, we're using 15 fractions, or some people will use 16 fractions. And then the DBCG SKAGEN 1 trial looked at comparing the conventional fractionation versus 40 gray and 15 fractions for patients that were undergoing regional lymph node irradiation. So stage 3 patients pretty much undergoing regional lymph node irradiation. And they looked at patients treated both after mastectomy or after lumpectomy. They delivered all of their tumor bed boosts actually as a simultaneous integrated boost, so a SIB. And their primary endpoint was 3-year ipsilateral arm lymphedema. This was presented in abstract form at ESTRO 2022, but the 3-year rates of arm lymphedema were just around 11% in both arms, with no significant difference. And there was no significant difference in any of the other outcomes, including local regional recurrence, distant metastasis, or death between the groups. So moderate hypofractionation is safe and feasible even for regional nodal irradiation. And so, as a rule, anytime you're doing whole breast irradiation, whether or not you're doing regional nodal irradiation, we think about 15 fractions or 16 fractions based on these trials. Here are some of the important dose constraints to note for moderate hypofractionation. And I've just kind of picked UK START B as an example. These constraints are pretty similar for the 16 fraction regimen. So remember that for UK START B, the prescription is 40 gray and 15 fractions. If you do 2.67 times 15, it's 40.05, and so that's where that 40.05 gray comes from. Now, anytime you're looking at plans for whole breast irradiation, we want the dose to be very homogeneous, right? We don't want a lot of hot spots, and we especially don't want hot spots in places like the nipple or very close to the skin or in the inframammary fold. Because if we have hot spots in the inframammary fold, remember the skin toxicity can be a little bit worse there, especially in large-breasted women where that skin kind of acts as a self-bolus. So for whole breast plans, we're looking for homogeneous dose coverage. We do want pretty good coverage, so we say that typically at least 95% of our PTV eval should receive 95% of the dose. So we aim for 95-95 coverage, but we can accept 90-90 coverage, and this may be necessary at times, especially if it's a larger breasted woman or if there's larger separation. In terms of the lumpectomy CTV, when we contour out kind of where the tumor used to be, we try to have slightly better coverage there. So there, we try to have at least 95% of the lumpectomy CTV getting 100% of the dose. And if we're drawing the lumpectomy GTV, so that's, kind of where the tumor used to be without an additional margin, we kind of want 100% of that lumpectomy GTV to receive 100% of the dose. The other way that we evaluate homogeneity is by limiting the hotspots, right? The more hotspots there are, the more heterogeneous your plan. So importantly, we want the V105%. So the volume of the breast that receives 105% or higher, we want that to be less than 10%. We want the V107 to be less than 5%, and we want the 110% to be 0. So we want nothing to be 110% or above. We want the 107% less than 5%, and we want the 105% dose to be less than 10%. And with regional nodal irradiation, it's more difficult to get good coverage there. So we typically aim for 90-90 coverage if we're doing regional nodal irradiation, but we can accept 80-80. Other organ at risk constraints that are important to know for this plan. So for the ipsilateral lung, we have a volumetric constraint. We want the volume that receives 20 gray to be less than 10 to 20%, but we can accept up to 35% based on the protocol, but typically we aim for lower, so less than 10 to 20%. The heart, we want the mean to be less than 2 gray. For the contralateral lung, we want the V5 to be very low, less than 5 to 10%. And for the contralateral breast, we want the V3 to be very low, less than 5%. So the biggest OAR constraints, if you're going to memorize any two of them, I would memorize the lung and the heart, and know that the ipsilateral lung V20, we ideally want it less than 10 to 20%, but can accept up to 35. And for the heart, we want the mean dose to be less than 2 gray. So these are some of the important UK Start B dose constraints. And it's, in practice, you'll probably look these up, and if you treat something often enough, you'll have them memorized. But especially for breast, it's good to have some of them memorized, especially for boards. Now, the one exception to using moderately hypofractionated radiation has been thought to be moderately hypofractionated radiation in a breast after immediate reconstruction. So let's say somebody has a mastectomy and then they have immediate implant-based reconstruction. These patients were often still treated with conventional fractionation, even in the modern era, just because all of the trials that we just looked at did not include patients that underwent immediate implant-based reconstruction. And so one trial that's ongoing that is looking at moderately hypofractionated whole breast irradiation for reconstructed breast is RT-CHARM, and the results are pending. But recently, the FABRIC trial was published, and this was presented at ASTRO 2023, and it was published shortly thereafter. And this is also a prospective randomized study that took place across 18 centers, and they included around 385 patients with stage 0 to 3 breast cancer who underwent immediate implant-based reconstruction, and they were randomized to receive conventional fractionation, 50 gray and 25 fractions, versus moderate hypofractionation to 42.56 gray and 16 fractions. They did allow for regional nodal irradiation if indicated. They did not permit any boosts, and they allowed for bolus at the physician's discretion. In terms of the endpoints, they found no significant difference in physical well-being or the overall toxicity profile between the arms. And these were kind of the primary endpoints of the study. So they found no significant difference in grade 3 or worse chest wall toxicity, no significant difference in physical well-being scores. The younger patients that were less than 45 years old actually had less nausea and side effects associated with moderate hypofractionation. And importantly, patients that took unpaid time off work required fewer hours off of work with the moderate hypofractionation, which makes sense, right? You have to come in for less number of treatments, and so you have to take less time off work. And so the Fabric trial is kind of the best evidence that we have that moderate hypofractionation is safe after immediate implant-based reconstruction as well. And it is associated with less side effects in younger patients and less unpaid hours off of work. So, radiation obviously contributes to a lot of financial toxicity for our cancer patients. And so it's important that if we're able to offer them with moderately hypofractionated radiation, it makes a big difference in their lives. And so Fabric is the evidence that we have supporting hypofractionated regimens in patients that have breast reconstruction. One thing to keep in mind is that with 15 to 16 fractions, the total regimen of whole breast irradiation takes either exactly 3 weeks or 3 weeks plus 1 day. If we're giving a boost, we typically give a boost in 10 gray and 4 fractions, or 12.5 gray and 5 fractions, or you can even do 10 gray and 5 fractions. So when we're counseling these patients, if they're getting just whole breast irradiation, it's around 15 to 16 fractions. If they require a sequential boost, then we're typically giving that sequential boost in an additional 4 to 5 fractions, making it a total of around 4 weeks of radiation with a boost. Recently, there was a trial that was published looking at simultaneous integrated boost, where the boost is kind of part of that whole package of 15 fractions of radiation. So let's take a look at that trial. RTOG 1005 looked at delivering a simultaneous integrated boost with 15 fractions. So they had over 2,000 patients on the trial who had undergone lumpectomy, and they looked at patients with stage 1 to 2 breast cancer that had age less than 50, either positive lymph nodes, LVSI, 2 or more close margins that were less than or equal to 2 millimeters, or 1 or more close margin with extensive intraductal component, which remember is 25% DCIS, hormone negative, grade 3, oncotype greater than 25, or having been treated with neoadjuvant chemotherapy. All of these factors that I just mentioned were reasons that the patients might potentially need a boost. So just think about when a patient might potentially need a boost for stage 1 and 2 breast cancer, and these are kind of the patients that were enrolled on the trial. They also allowed patients that had DCIS with grade 3 and were less than 50 years old. So the randomization was actually to conventional fractionation or moderate hypofractionation with 42.56 gray and 16 fractions plus a 6 to 7 fraction boost. And the experimental arm was 40 gray and 15 fractions to the whole breast with a simultaneous integrated boost to 48 gray, so 3.2 gray per fraction to the boost area, to the lumpectomy cavity. And they allowed for both 3D and IMRT planning, but 75% of the patients actually received 3D planning. They found no significant difference in the 5-year ipsilateral breast tumor recurrence in either arm. So it was just around 2% in both arms, and the trial met non-inferiority criteria. They also found no significant difference in toxicity, patient-reported cosmesis, or physician-reported cosmesis. And so this trial is important because, as we just said, if we're delivering a sequential boost, then we do 3 weeks of moderate hypofractionation of the whole breast, but then we still require an additional week. So the patient has to come in every day, Monday through Friday, for 1 more week to get the boost. With this regimen from RTOG 1005, it gives us an option for patients that are receiving a boost to get away with, just 15 fractions total. So it cuts down that treatment. Here are some of the dose constraints that were used in RTOG 1005. For the sake of time, I won't read through them, but I will leave them here for your reference. What I do want to do very quickly is to point out the heart constraint for RTOG 1005. Keep in mind that the dose that they allowed for volumetric constraints was a little bit different depending on if it was a right-sided or a left-sided breast treatment. And the mean dose was ideally less than 3.2 gray, but they deemed 4-point gray acceptable for the mean dose. I want to mention a trial, a retrospective study published by first author Darby et al. In NEJM in 2013. This was a retrospective study that showed that there was a correlation between the rate of major coronary events and the mean heart dose. And the rate of major coronary events actually increased linearly with the mean heart dose at 7.4% per gray. Now, importantly, this is a relative risk. So if, whatever the patient's relative risk of, heart diseases, so say it's 1%, then it's a 7.4% relative increase. It doesn't mean that that patient has a 7% chance in their lifetime all of a sudden now of getting a major coronary event, right? Because if that were the case, that would be, very high heart toxicity. So this is a relative rate, but this number does come up. So keep in mind, relative increase in toxicity of 7.4% per gray, and the rate kind of increases linearly with the mean heart dose. So that was moderate hypofractionation. We're giving radiation dose at just around 2.66 gray per fraction. Now let's talk about extreme hypofractionation with some whole breast irradiation options that only involve 5 total treatments. So you'll notice a pattern here that a lot of these hypofractionated regimens are coming from the UK. And I think it is really kind of the UK that's studying these more and more hypofractionated regimens and kind of setting that standard for shorter overall treatment time. So UK Fast Forward is a trial, obviously came out of the UK, and they compared a few different regimens to conventional fractionation. And the winner of the trial ended up being 28.5 gray in 5 fractions, given once a week over a total of 5 weeks. So in this trial, they included, much lower risk patients. So these patients were greater than or equal to 50 years old. They had tumors less than 3 centimeters, and they were node negative, and they underwent breast conserving surgery. And the 3 arms of the trial were 50 gray and 25 fractions, which is conventional regimen, 30 gray and 5 fractions given once a week over 5 weeks, or 28.5 gray and 5 fractions given once a week over 5 weeks. And the primary endpoint was the change in photographic breast appearance. So the big takeaway from this trial is that there was no significant difference in terms of toxicity or breast appearance with the conventional regimen compared to the 28.5 gray regimen. However, with 30 gray and 5 fractions, there was actually worse moderate or marked normal tissue effect. There was worse photographic breast appearance, and there was worse physician-assessed shrinkage, induration, telangiectasia, and edema. So 30 gray and 5 fraction arm was significantly worse in terms of toxicity, but 28.5 gray and 5 fractions was not significantly different, and this was kind of deemed the winner of this trial in terms of an acceptable regimen. Now, we are going to talk about more trials that look at 5 fractions given every day, Monday through Friday. And, we know for a lot of disease sites that overall treatment time matters, and it's probably better to give the radiation in a shorter amount of time. And so giving it every day, Monday through Friday over 5 fractions is probably better than giving treatment once a week over 5 weeks. However, for older patients, especially if they have lower risk disease, they often have a hard time coming into clinic every single day, Monday through Friday. If they're coming from far away or something like that, it ends up being a lot for them. And so it's good to know that this option of radiation once a week over 5 weeks, it's good to know that it exists for the patients that, maybe want that option. So UK Fast Forward then is the next trial that now looked at giving 5 fractions in just 1 week. Okay, and in this trial, the standard arm was not conventional fractionation. It was actually moderately hypofractionated, 40 gray and 15 fractions. So if you need a way to remember what the conventional arm was, think, UK Fast Forward. We're now moving forward in time. This trial was done in the 2010s, and so moderate hypofractionation already was kind of the standard of care at this point in the UK. So the standard arm in this trial is 40 gray and 15 fractions over 3 weeks. And then this trial also had 3 arms, and the 2 experimental arms were 27 gray and 5 fractions over 1 week and 26 gray and 5 fractions over 1 week. And the primary endpoint was ipsilateral breast tumor recurrence. So there was no significant difference in 5-year ipsilateral breast tumor recurrence across the regimen. It was just around 2% across all of the groups. However, the side effects were significantly worse with 27 gray. There was higher rates of moderate or marked clinician-assessed normal tissue effects in the breast or the chest wall with the 27 gray and 5 fraction regimen. And so 26 gray and 5 fractions kind of emerged as the winner. So the takeaway from UK Fast Forward, 26 gray is non-inferior in terms of local control and toxicity at 5-year follow-up. And remember what the standard arm was on this trial. It was 40 gray and 15 fractions because we're now in UK Fast Forward, moving forward in time. So moderate hypofractionation is now the standard of care. Here are the dose constraints for UK Fast Forward. So again, the coverage, we want 95-95 coverage. We want the Dmax to be 110%. We want the 105 to be less than 5. We want the 107 to be less than 2%. And, you know, that's pretty similar to what we saw for those UK Start B dose constraints. We wanted the V110 to be 0. For UK Start B, we wanted 105 less than 10%, 107 less than 5%. In this regimen, we want 105 less than 5%, 107 less than 2%. But again, Dmax of 110%. The ipsilateral lung constraint for UK Fast Forward is V8 less than 15%. So we want no more than 15% of the lung to receive 8 gray. For the heart, we want no more than 5% of the lung to receive 7 gray, and we want no more than 30% of the lung to receive 1.5 gray. So these are sort of the important dose constraints for the UK Fast Forward regimen. Chugging along, we've talked about moderately hypofractionated whole breast irradiation, extremely hypofractionated whole breast irradiation, and now let's get into some trials looking at partial breast irradiation. So UK Import Low was probably one of the first trials to ask this question of, do we need to be radiating the whole breast, or can we kind of get away with treating a smaller volume of disease? Just treat the area where the tumor was removed. Now with partial breast irradiation, one thing to keep in mind, and you can probably imagine, if the tumor is smaller and we want to target just the partial breast, that makes sense because we're sparing a lot of normal breast tissue from radiation. However, if the tumor size is larger, or if the breast itself is so small that the tumor takes up most of the breast volume, then at that point, if you're doing partial breast irradiation, you might as well be treating the whole breast because it's really hard to spare any breast tissue, right? If the tumor is too big or the breast itself is too small. And so, have that in your mind as you think about partial breast irradiation, because not everyone is a candidate for partial breast irradiation just because of either the tumor size or their breast anatomy. So UK Import Low included patients with a tumor less than or equal to 3 centimeters. That's an important number to kind of keep in the back of your head, 3 centimeters for the tumor. And they did allow N1 disease, so 0 to 3 positive nodes, and they required clear margins of at least 2 millimeters. The patients were randomized to one of 3 arms, so either 40 gray and 15 fractions to the whole breast, which was their control, or 36 and 15 to the whole breast with a 40 gray SIB just to the boost volume, or 40 gray and 15 fractions to the partial breast. And the way that they did the partial breast irradiation was using mini tangents. So it's still kind of a 3D plan with oblique tangents, but these are now mini tangents. So you can kind of see in the picture, you're sparing some of that inferior and superior breast tissue from the radiation, but you're still kind of in the axial plane, you're kind of treating all that region of the breast with your mini tangents. In terms of outcomes, the reduced dose and the partial breast arms were non-inferior in terms of ipsilateral breast tumor recurrence, as well as normal tissue effects including photographic, patient-reported, and physician assessments. So the 5-year ipsilateral breast tumor recurrence was, less than 1%, and they found significantly decreased change in the breast appearance and the firmness of the breast in the experimental arms. So UK Import Low importantly used 40 gray and 15 fractions. They used mini tangents, and in their partial breast arm, they found that, toxicity and ipsilateral breast tumor recurrence was non-inferior. Another trial, and this one is from the US now, looking at partial breast irradiation, is the NSABP B39. It's also called RTOG 0413. This trial looked at accelerated partial breast irradiation delivered in 10 fractions given BID, so twice-a-day treatments at least 6 hours apart. They took patients, very similar to what we just saw in Import Low, with tumor size less than or equal to 3 centimeters, up to 3 nodes, and negative margins, so stage 1 to 2 breast cancer, and they had to have undergone lumpectomy, and they were randomized to whole breast versus partial breast irradiation. This trial, keep in mind, was in the US, and the US was slower to adapt that moderate hypofractionation. So the standard arm in the US trial is 50 gray and 25 fractions over 5 weeks, so conventional radiation. And then the partial breast irradiation, they allowed for both brachytherapy and external beam radiation. So for brachytherapy, the dose was 34 gray and 10 fractions, and this was used by just under 30% of the patients. And then the external beam dose was 38.5 gray and 10 fractions, which was used in around 70% of the patients. So the treatments were, for whether it was brachy or external beam, the treatments were BID at least 6 hours apart, delivered over no more than 8 days. If you need to remember kind of why the external beam dose was higher, so with brachytherapy, there's a little bit of, inherent dose escalation, and the dose is just a little bit higher with brachytherapy because of its radiobiology. And so with brachy, they gave 34 and 10, but the thought was that to kind of meet that with the external beam treatments, we need to escalate a little bit. So they did 38.5 gray to kind of match the, theoretical dose that was given with the brachy. So the external beam dose was therefore higher, but it was, both of them were 10 fractions delivered BID. Now, in terms of the results, there was less than 1% absolute difference in the ipsilateral breast tumor recurrence between the arms. So the 10-year tumor recurrence was 4.6% with whole breast irradiation versus 3.9% with partial breast irradiation. Yet, it did not meet the equivalence criteria of the trial. And so that's an important point. There was a low difference, but the equivalence criteria for the trial were not met. The toxicities were similar between arms. They had slightly worse toxicity in the accelerated partial breast irradiation arm, and that was kind of attributed to potentially the BID fractionation that was used here. But the absolute difference in local recurrence was very, very low, but still it did not statistically meet the pre-specified criteria for equivalence. And keep in mind that, these trials also did enroll some higher risk patients, so node-positive patients. Of note, there is a trial from Canada called the RAPID trial that used the same exact external beam partial breast fractionation, so 38.5 gray in 10 fractions given BID, and they did not include node-positive patients. And in the RAPID trial from Canada, the accelerated regimen was non-inferior for ipsilateral breast tumor recurrence, but acute toxicity was the same, but the late toxicity was worse in the APBI group, so the accelerated partial breast irradiation group, mostly due to cosmesis. So in RAPID trial, again, tumor recurrence non-inferior, acute toxicity the same, late toxicity was worse, and again, this was thought to be kind of due to that accelerated BID fractionation. Now, for accelerated partial breast irradiation, or APBI, I have actually never seen the regimens used in RTOG 0413. I've only seen the Florence regimen used, and I think because it's kind of the most convenient one, this might be the most commonly utilized one. So the Florence APBI trial, this trial obviously was run in Florence. You might also hear it called the Livy trial because Dr. Livy was the PI on the trial. This trial looked at 30 gray in 5 fractions compared to conventional radiation plus boost. So this was a single center phase 3 randomized controlled trial of around 500 patients. They included patients over the age of 40 with tumor size less than or equal to 2.5 centimeters and negative margins. Remember, again, the conventional radiation plus a 10 gray and 5 fraction boost using 3D technique was the standard arm, and then the experimental arm was accelerated partial breast irradiation, 30 gray and 5 fractions. So initially, they were doing the treatment every other day, so 5 fractions over 2 weeks, but in the updated abstract, they actually changed to daily fractionation, and for this APBI arm, they required using the IMRT technique. So there was no significant difference between the arms in terms of ipsilateral breast tumor recurrence or survival. The ipsilateral breast tumor recurrence was just around 3% in both arms. And they found significantly improved cosmesis and improved acute and late toxicity with APBI. The one kind of caveat is that the daily fractionation, so doing 5 fractions once a day over just 1 week, it might lead to higher rates of kind of low-grade skin toxicity, so higher, especially grade 1 toxicity. But I've seen kind of both regimens used, either daily 5 fractions or every other day over 2 weeks for that 30 gray and 5 fractions. And I think it kind of comes down to physician preference. So importantly, from the Florence APBI trial, also sometimes called the Livy trial, the winning regimen is 30 gray and 5 fractions partial breast irradiation using IMRT, and it actually had improved acute and late toxicity as well as cosmesis with this partial breast accelerated fractionation. So here are the APBI dose constraints from the Florence regimen. Again, we want at least 95% of the tumor to receive 100% of the dose. And remember, the target in APBI now is just the lumpectomy cavity with a CTV and then a PTV margin added on top of that. So we want at least 95% of that PTV to be getting 100% of the dose. In terms of the Dmax, we want no hotspots above 105%. If you recall from UK Start B and from the UK Fast Forward regimens, the maximum hotspot that we allowed was 110%, but in this case, we want a maximum hotspot of 105%. In terms of the other dose constraints, so the uninvolved breast is important, right? Because if you're doing APBI, then you need to be sparing a certain amount of uninvolved breast. So the uninvolved breast constraint is V15 less than 25%, but up to 50% was acceptable in the trial. So that means that the volume receiving 15 gray should be no more than 25% of the breast volume. Again, up to 50% is acceptable. And this is where that tumor size and the size of the breast becomes important, right? If the tumor to breast size ratio is too large, then you're not going to be able to meet this dose constraint. And then at that point, you might as well be doing whole breast irradiation because you're not sparing enough breast. So the uninvolved breast dose constraint is V15 gray less than 25%, but up to 50% is acceptable. The maximum dose for the contralateral breast, we want to keep it less than 1 gray, but up to 2 gray is acceptable. For the ipsilateral lung, the V10 gray should be less than 20%. Contralateral lung, just kind of divide everything by 2. So the V5 should be less than 10%. So ipsilateral lung, V10 less than 20, contralateral, V5 less than 10. And then the heart constraint is V3 less than 10%. So different societies have guidelines published on what is acceptable for partial breast irradiation, and these guidelines typically divide into suitable, cautionary, and unsuitable. So suitable is what's, it's like green light, yellow light, red light, right? So unsuitable, you definitely should not be doing partial breast. Suitable is definitely okay to be doing it. And cautionary, it's a physician decision, and you really have to think about it. So ASTRO, ABS, ESTRO all have guidelines. ASTRO recently actually updated their guidelines on partial breast irradiation, and they made them a little bit wider. So for the ASTRO guidelines for invasive breast cancer, grade 1 to 2 ER positive tumors that are less than or equal to 2 centimeters in size are considered suitable, and the age is greater than or equal to 40 years old. So if a patient is less than 40 years old, APBI is not considered acceptable. It's actually unsuitable in these criteria. Other unsuitable criteria include presence of positive lymph nodes. Even if you're not doing regional nodal irradiation, positive lymph nodes makes you unsuitable for partial breast irradiation. Positive margins is unsuitable. You cannot have positive margins. If you have a known BRCA mutation as well, that's considered unsuitable for partial breast irradiation. The rest, everything that falls in between that is kind of cautionary, right? So grade 3 is cautionary, ER negative is cautionary, size that's greater than 2 or less than or equal to 3 centimeters is considered cautionary. HER2 positive tumors that are not receiving anti-HER2 treatment, LVSI, and lobular histology. For DCIS, it's similar. So grade 1 and 2 are considered suitable. Grade 3 is considered cautionary. Age greater than or equal to 40 is suitable, and tumor size less than or equal to 2 centimeters is suitable. 2 to 3 centimeters is considered cautionary. And really more than the tumor size, the tumor size matters and you should think about it, but also think about the tumor size to the breast volume ratio. Because if the tumor is small, but the breast is also too small, then meeting those dose constraints for the uninvolved ipsilateral breast can be pretty challenging. So those are all of the regimens I wanted to talk about for breast radiation. We talked about moderate hypofractionation, extreme hypofractionation, and partial breast irradiation. And when we're doing partial breast irradiation, typically accelerated partial breast irradiation is what we think about. The very last thing that I want to cover is a trial looking at re-irradiation. RTOG 1014 was a phase 2 trial looking at re-irradiation in patients with prior breast-conserving therapy. So this is a small phase 2 single-arm trial with 58 patients. They had to have a tumor recurrence that was less than 3 centimeters, and they had to have prior lumpectomy and adjuvant whole breast irradiation more than a year ago. So they didn't use any patients that had, radiation within the last year. The treatment that they offered this time was repeat breast-conserving surgery, followed by partial breast radiotherapy using a 3D technique. And the dose that they used was 45 gray in 30 fractions delivered BID, so twice daily treatment. And since it was 30 fractions, it took 15 days total. So the treatment took 3 weeks total. Now, a lot of times when it comes to re-irradiation, you'll notice these BID regimens. And the rationale behind that is that late toxicity is kind of a function of the dose per fraction. And the idea is that in a previously radiated tissue, they're more likely to experience late toxicity. But maybe if we decrease the dose per fraction, they'll still get acute toxicity, but hopefully we can spare them the late toxicity. At the same time, when we're dividing it up into, smaller fractions, smaller dose per fraction, we're creating more fractions, right? But we don't want to increase the total treatment time by too much. And so BID is a nice way of decreasing the number of days that a patient is being treated, but at the same time, also decreasing the dose per fraction. So lower dose per fraction, more number of fractions, but then we kind of condense the treatment time by making it BID treatments. And we deliver the treatments at least 6 hours apart in order to kind of allow for some repair of the tissues, the normal tissues that are being treated. So bottom line, partial breast irradiation in the context of re-irradiation, 3D technique, 45 gray and 30 fractions BID. The results were actually really good. The 5-year ipsilateral breast tumor rate was just 5%. The 5-year mastectomy rate was only 10%. And the overall survival and the distant metastasis-free survival were 95%. The rate of grade 3 toxicity was only 7%, and the rate of grade 1 to 2 toxicity was 50%. So given that the alternative in this scenario is mastectomy, reirradiation with partial breast treatment to 45 gray and 30 fractions BID is actually an effective approach. And breast conservation was achieved in 90% of patients with low risk of a second recurrence, I should say a third recurrence actually, and low rates of grade 3 plus toxicity. So this is kind of the regimen to know if you ever encounter a patient that has previously undergone whole breast irradiation and is once again a candidate for breast conserving surgery. Now that was just a ton of information, a lot of different trials going over different regimens for breast cancer. So let's take a moment to kind of summarize everything that we've talked about. So remember, in the old days, we used to do conventional fractionation, 50 gray and 25 fractions. We do not really do that anymore. The only context that I'm aware of that we were really doing it was in patients that had an immediate reconstruction following surgery. But based on the Fabric trial and the ongoing RT-CHARM trial, even that, I think there's an argument to consider moderate hypofractionation in these patients. So what are the moderate hypofractionation regimens? From the Canadian study, we have 42.56 gray and 16 fractions. And then from the UK study, we have 40 gray and 15 fractions. In these scenarios, you're typically giving a boost of 4 to 5 fractions, but RTOG 1005 gave us a regimen for actually doing a simultaneous integrated boost, so the patients only require 15 treatments as opposed to 19 to 20. For extreme hypofractionation, we have UK Fast and then we have UK Fast Forward. So in UK Fast, the regimen is 28.5 gray in 5 fractions delivered once a week over a total of 5 weeks. So that's, starting to get there, but then UK Fast Forward showed us that 26 gray in 5 fractions daily was non-inferior. And remember, in UK Fast Forward, the standard arm was actually moderate hypofractionation of 40 gray and 15 fractions. UK Import Low used mini tangents with the same UK Start B dose of 40 gray and 15 fractions and showed that partial breast irradiation was non-inferior for patients with sort of smaller tumors that were lower risk. And then the Florence APBI regimen used 30 gray and 5 fractions with IMRT, and this treatment can be given daily or every other day. And then finally, we talked about RTOG 1014 with 45 gray and 30 fractions BID partial breast irradiation in the context of retreatment. If you have a hard time remembering the UK trials, I have a little, maybe something that I can help provide to kind of a mnemonic to remember these. So UK Start, we're starting to think about hypofractionation, and so that's kind of the first step, which is moderate hypofractionation. UK Fast, we're getting a little bit faster by decreasing the number of treatments, but we're still taking the same amount of time, which is 5 weeks. And then finally, UK Fast Forward, we're really thinking forward and kind of fast forwarding the treatment. So the 5 treatments are now given within a single week, Monday through Friday. And then UK Import Low, I just think about low and kind of using mini tangents. And so that's your partial breast irradiation study. So hopefully that, is a helpful mnemonic to kind of keep these trials straight. But other than that, if you look at them long enough, I think you will definitely start to learn them. And so that actually wraps up everything that I wanted to talk about for breast cancer for the time being. Maybe one day in the future, we can have a talk kind of looking more at the technical side of radiation treatment planning for breast cancer. Because for board exams and things like that, you do have to kind of be able to verbalize how to do radiation planning for the breast, how you set up your fields. There's monocentric versus dual isocentric approach. I think that is something for an entirely different topic. In this kind of initial breast cancer treatment series, what I really wanted to do was tell present the evidence for why we do what we do, but kind of present it as a story in a way that makes sense. It didn't always make sense to me when I was first learning these things during residency. It's helpful for me to have somebody kind of explain it in context, I think. And so hopefully we've been able to do that. I know that all of these talks have been quite long, but hopefully they've been helpful to you. Hopefully the data makes a little bit of sense, and hopefully you've kind of taken away some major take-home messages that kind of stick with you. And so if you've been listening along with the breast cancer series, or even if it is just this particular talk, I thank you so much for your time. Again, really hope that these are helpful to you. Please keep in mind that we have not been able to cover every single trial that exists for breast cancer because there's just far too much to get through. But hopefully you have some important big picture ideas that have kind of stuck with you. So with that, thank you guys so much for your time.